Good morning, good afternoon, and good evening to those who are listening. I'd like to thank you to join our session today. I'm Dr. Morshada Chaudhary, Technical Lead for Health at Opportunity International. Our session title is Reimagining What's Possible, Health and Financial Inclusion Through Women's Voices. For too long, health has been defined through the lenses of educated global north. But when you ask a woman, are you well? It often doesn't translate as a combination of physical, psychosocial well being. It more reflects coping with daily burden like children's health, education, bills, other bills, so on and so forth. Health is never a priority to her or until she or someone in her family becomes sick. So let me share a personal story of mine. I met one woman in rural Bangladesh. Assume her name is Asma, a mother of two children, a successful entrepreneur. She had built her own business. She also employed her husband. She was visibly malnourished. And then I was chit-chatting with her, and I was curious to know what she eats. She told me that she only eats rice with little bit curry. So it's not that she can't afford. It's basically she doesn't like it. She just doesn't like protein, fruits, or dairy. And what happens? She becomes feel sick frequently, and she ends up with spending a lot of money for healthcare. So imagine if she knew that how to take care of her health, and if she practiced that, she could have saved more money. She could have be more productive. She could have earned more. So that's why we are here today, to move from narrow clinical success towards women-led definitions of well-being, and to align public health, inclusive finance, and policy around what actually matter to a women's life. Let me introduce our eminent panelists. Sitara Merchant Carter, CEO, Swiss Capacity Building Facility, Financial Inclusion and Cross-Sector Partnerships. Professor Olga Bioska, Yunus Center for Social Business and Health, Glasgow, Caledonian University, Evidence at the Intersection of Finance and Well-being. Dr. Neeta Rao, Public Health and Health Financing Expert, Policy Protection and Systems Reform. So I'm going to ask the panelists, all three panelists, same question, and we'll keep this fast and practical. So let's start with Dr. Neeta Rao. So Dr. Rao, please tell us a bit about your focus area of work and share with us what has opened your eyes to the need of public health to better define. Neeta, what do you?
Thank you so much for this opportunity. I'm really honored to join this conversation. So, for the past 2 decades, I have worked at the intersection of health systems, health financing, and risk protection, essentially looking at how we can make health more holistic and equitable, especially for vulnerable communities. One moment that has stayed with me from a visit to a remote hilly region of India, I saw women who began their day before sunrise, cooking, fetching water and firewood, caring for the families, working in the fields, and doing household chores till late at night. Many came to the clinic anemic, undernourished, with repeated miscarriages, and also complaints of uterine prolapse. And most of the programs around them were focused only on curative care, not the daily realities that were shaping their health. And those realities are not unique to hilly region. They persist across geographies. More than 40% of health spending in India is out of pocket. And for women, a health crisis often means pawning jewelry, skipping their meals, or pulling children out of school, especially girls. When I have asked women, whether it be in Mumbai slums or rural Jharkhand, of what being healthy actually means to them, the answers go far beyond clinical terms. They say, I need to be strong enough to work and feed my family. I don't want to fall sick and get into debt. I really want to have peace of mind and have good energy to look after my children. So these voices actually remind us that health is not biological. As you rightly said, there are a lot of factors, social, cultural, financial, and largely shaped by the degree of choice and control that women have over their lives. I'm glad to be working with Opportunity International, Uplift, and Swiss Capacity Building Fund towards better defining health for women, starting with their voices. This process begins by understanding from communities how they perceive health, the financial stress that they face, and how they cope with their expenses. This has led to the creation of a primary healthcare service delivery at the doorstep of urban poor, which is complemented by 24 by 7 helpline, referral networks, community volunteers, and most importantly, a bouquet of financial products, including mutuals or insurance, wallets or savings, and health loans. So, if we truly want to improve health outcomes, we must define health from ground up through women's lived experiences.
Thank you, Nita. So I'll go to Sitara with the same question.
Great. Thank you. It's a pleasure to be here. At SCBF, we focus on expanding access to inclusive finance, whether it's through health, agriculture, or other essential services for low-income and underserved communities. What really opened our eyes is the client voice. Similar to what was said earlier, through our outcome studies, which are independently conducted, we heard that from men and women about how access to finance shapes their lives. And what they tell us is it's not only about being healthy. It's not just about the absence of illness. It's about having security to care for your family, being able to continue working when shocks happen, and feeling resilient and hopeful about the future. For us, well-being sits at the intersection of health, livelihoods, and financial stability. This means that public health can't be defined as an isolation. It must be taken into account whether people can afford, how they recover from shocks and setbacks, and how they maintain dignity. This is why linking financial inclusion to health outcomes is so critical for us, and where we see an important role for donors and practitioners and innovators to work together. Back to you.
Thank you, Sitara. Over to you, Olga, with same question.
Yeah, so just, well, thank you very much for inviting me, Moshida. It's such a pleasure to be here today and thrilled to talk with women about women's health. So I work in the Unit Center for Social Business and Health, where we've been exploring for the last 13, 14 years the connection between financial inclusion and health and well-being. And I'm a professor of economics in its broadest sense. And you'll see why I'm saying this. So when we started our work, everyone was like, oh, but financial inclusion, why are we going to measure financial inclusion outcomes? Health outcomes deriving from financial inclusion makes no sense. Slowly but surely, and particularly after COVID, people started to understand that there was a very clear connection between money, financial inclusion, and health. But we discovered that part of the issue was that, health means different things to different people. And health needs to be measured in its broadest sense. And this is what I'm talking to, perhaps including, different disciplinary in academia perspectives, but also, the more broad definitions of health that would encompass and would interest different type of organizations. So what happens currently is I feel, for example, academic journals are focused on particular measures of health that are going to work to develop qualities, etc. Government is focused on particular measures of health, but this is because they're all working in silos. So in academia, there is no interdisciplinarity of, social policy plus, financial policy and regulation plus health. Whilst in public health is like, oh yeah, it's a complex intervention, but perhaps too complex to measure. So it is really important and really determinant that we start using more holistic measures of health, because one single measure of health doesn't work. And I think to start a more holistic conversation where everyone wants to participate in the conversation, we need to have this more global, holistic health measure.
Thank you, Olga. All three of your comments remind me that acting in silos is no longer a viable option. That is why also Opportunity International is working in the intersection of inclusive financing and health together. The health intervention is designed in collaboration with the community so that it responds to the needs of the community. So let's go to question number 2. In 1948, World Health Organization defined public health as a state of complete physical, mental, and social well-being, not merely an absence of disease or infirmity. So it's for a long time, right? So why does public health still default to a narrow definition of absence of disability or illness as the primary indicator of success? What barriers keep us from adopting a truly holistic, meaningful, and women-led approach? Let's go to Olga because she is the professor and she's the researcher. Let's hear from her first. Olga, over to you.
Thank you, Morshida. So I think, listen, I think in academia, we're very narrow in the measures that we use. But because we want to, it's a little bit linked to what I was saying before, because we want to appeal to particular silos. So if you're targeting your health economics public health silo, then you'll be using particular measures specific to them that interest them, that they understand. Same happens if you're talking to financial regulators. So let me say an example. So today, what's worrying me is we are designing an impact evaluation for a microfinance institution working in the UK. They give productive credit, very small loans for a business. And they are quite niche and they do something that nobody else does in the UK. So we are thinking, and we want to measure the impact of those loans for a business creation on health and well-being. Now, the measures that we're going to use, some of them have been imposed by the health world. You're going to use your EQ5D, your Web scale, all these scales that measure health. However, we know, I am fully convinced that the mechanisms and the pathways through which we're going to find an impact on health from financial inclusion are going to be very different. They're going to be related to, social capital. They're going to be related to nutrition, as you were talking to before. Yet they're going to be related to stress or absence of stress, to better manage their inflow of money. So, income alone cannot be a primary measure, but also narrow measures of health are not going to work. So I think that one problem that we're struggling now is like the women value outcomes. The women that, their value outcomes that we are not measuring. And we need to find what outcomes are those in different contexts with different programs, so different interventions that we call, right? Because if not, many positive outcomes are not measured and they're not captured. And in global health, we all know, a single standardized metric, it won't work. It won't work across context. It won't work across interventions. So thank you.
Thank you, Olga. Very insightful thoughts. Neeta, over to you. What do you think?
Yeah, very interesting what Dr. Olga mentioned. For me, the way I look at it is like there are 4 key barriers that comes to my mind when it comes to looking at health holistically. The first part is the measurement, which actually Professor Olga covered very beautifully. But what I want to emphasize here is what gets measured gets done. So our systems are focused on mortality, morbidity when we look at health, and service utilization. Maybe because they're relatively easy to count. But we rarely measure what it truly means for women, like reduced financial stress, decision-making power, dignity of access. Now, when we talk about well-being, it is measured by a range of metrics, as Professor Olga mentioned, and it is multidimensional. It requires subjective and objective indicators, which all come together to give a holistic picture of an individual's quality of life and functioning. And capturing this is not only difficult, but it requires a lot of investment and intent. The second barrier or challenge that I see is siloed approach, which all of us are aware. Within health itself, there are silos. And then there is siloed approach of the social determinants to health. So nutrition, water, sanitation, education, employment, All of this shape women's health, but we continue to plan and fund them in silos. So, without integration, we are only treating the symptoms of health and not actually addressing the root causes of health issues. The third challenge that I see is fragmented financing. Health and finance still work separately. So, for instance, Ayushman Bharat, which is the largest health assurance program in India, which covers for hospitalization. But what we hear from women, one is about the coverage part itself. There are issues there. But what women tell us is that the real burden is indirect costs, transport, wage rates, medical expenses, and access to healthcare. So
Nita, we can't hear you. Can you hear us? While Nita is coming back, let's hear from Sitara. Nita, you can add later on if we have time. Yeah.
Thanks, Dr. Mashida. I think the question is a really important one. And I think what we need to do is really hear the client's voice or the end beneficiary's voice. For us at SCBF, we primarily focus on development of financial products and services. And so we fund the technical assistance. What we see that in our work is that public health systems often measure what's so-called easiest to measure or track, which is mortality, disease incidence, hospital visits, rather than what people themselves define as well-being. So when you ask a woman, what does it mean to you for well-being? What is your voice? I think that's where we need to start shifting the focus, because I think we can go through and have lots of different metrics, but at the end of the day, if the end beneficiary or the client, the low-income person or woman says that this doesn't work, then it's irrelevant almost. And what we're hearing is that women tell us that their health is tied to whether they can provide food, whether they can keep children in school, how they manage stress or debt when someone falls sick. And the barriers to adopting holistic women-led approach are both structural and cultural. So I think we also need to look at it from that perspective. We need to see how what makes it hard to connect the dots. Because I think at the end of the day, the cultural voices are still underrepresented in how success is defined. And I think that's the key shift that we need to move. At SCBF, we've learned that women's perspectives basically shape the product. So we, and a lot of us have heard about this and use it in the development of financial products, but really asking them, how would a financial product be tailored to meet your needs? And how do you know, what does success look like for you? That's really where I think we should be moving, is really shifting to listening to those lived experiences, and shift the public health from treating disease to truly building resilience. Back to you, Marcia.
That's very true, Sitara. So Nita, would you like to add something?
I'm really sorry, I lost connection. No, I think as Sitara mentioned, we really need to, the point that I was mentioning is stop doing top-down design and really listen to women and their voices. And, just wanted to share an example of Jivika program in Bihar, which was built on health and nutrition into self-help groups. And women not only improved the health outcomes, but the peer networks actually supported mental health and helped them reduce their debt. And similarly, Uplift Mutuals has shown how health loans, maternity savings, and insurance help urban women, poor from the poor strata, manage health shocks with flexibility and dignity. So, if we really want systems that can serve women better, our measurement frameworks must not only track lives saved, but actually lives improved. So, thank you. Over to you, Morshida.
Thank you, Nita. I think, yeah, if you see that SDG vector for health, it's basically like emphasizing on disease and on knowledge, not what women feel about health and well-being. And also, you mentioned resilience. So understanding being well encompasses both being healthy mentally and physically, and also being resilient. And that means that being able to manage like health shocks, as you just mentioned, without bankruptcy or without any stress. So Opportunity International is also implementing a holistic health intervention with microfinance partners, where health and resilience is the ultimate outcome. This has opened a big opportunity for us to reduce health resilience from women's perspective, basically. So let's move on to question number three. If we want to measure health holistically, as we have discussed so far, from women's perspective, where should we start? What should we build, change, or stop? Let's go to Olga first.
Yeah, so well, we all know that women's health remains under researched, and it's not globally, right? So, and we have a very recent example in COVID that I was reading about the other day. So, this male-centric lens of research kind of translates into everything. This is still influential. So, for example, during COVID, there was a dismissal of actual COVID, but also the side effects of the vaccines on menstruation. While, for example, the effect on pericarditis, there was an increased risk of pericarditis in young men. That was like, compared to something that was real for women, a little bit overdone. So, in a way, this is still happening, and we need, it's improving. And there are many voices that are out there, saying, well, women's health is different. There are different phases. It's we need to consider different outcomes, perhaps. But the research is still too often led by men and with this male-centric approach. So I think one of the things we need is for more women to lead research agendas. And even though the momentum is stronger in the global north, and we have a lot of women-led approaches, participatory approaches, particularly in the UK where I work, we're seeing that a lot. We are seeing, more participatory measures and more funders accepting participatory measures and new measures that are perhaps a little bit more controversial because it's not the traditional thing. So we are moving. We perhaps need to move a little bit faster. We need to create spaces as well where women are taken seriously, but not only that they're taken seriously, that they feel free to speak. Create future leaders, create women. It's always the men in the room who ask the questions, who make the comments. It's very rare that a woman takes the microphone when she's given the opportunity. So I think in government and in academia, women's voices need to be heard loud and clear.
Thank you, Olga. Let's hear from Sitara.
Sure, thank you. I think if there was a few things we should do, I would just limit them to three. We should start with the way we design and fund solutions. So how do we integrate health with finance, and how do we measure resilience and empowerment, not just services delivered, which has been historically the case. I think the other key component is in an environment that we're in right now, where there is not a lot of funding. As you know, there's been development aid that's been shifting to more of the defense aid or defense. We have to start putting money in the hands of the consumer. We have to start making financial services available, because if you look at the system, if there's not money in the market for grants or sort of subsidies and all that, and there's only so much you can do in terms of lowering the cost of access, the other lever really is about how do you actually put money in the hands of the consumer, and that's through financial products, whether it's bundle solutions of insurance and savings, or whether it's insurance alone or loans. I think that's where we need to shift. And then I think the other key piece is when we talk about insurance, for example, really having insurance that supplements what exists in the country. So really meeting the country, the population where they're at. So if there is, for example, universal healthcare in the country, then having a supplemental healthcare that covers the gaps that is not covered by the universal healthcare. So those are my three things. Back to you, Marcida.
Sitara, over to Nita.
Thank you for that question. I think the first step is to shift the power to communities, especially to women. And I would like to quote Melinda French Gates here, where she said, bring women not instead of men and boys, but along with them and on behalf of them. As the previous speakers have mentioned, definitely we need to build leadership among women. Programs like Women Lift Health are showing how investing in women's leadership transforms not only who sits at the table, but the outcomes we achieve through that. When women are empowered, everything rises along with them. So health improves, children thrive, and communities grow stronger. Again, participatory measurement systems are extremely important while they are very tough. And as Sitara mentioned, looking at blended financing models or bundled products where you integrate public health insurance with microfinance savings and other products. And there are many examples, right from Uplift to Seva, which shows how women can take charge of their health with such kind of models. And what we need to change is how we design and finance health. Move from programs that are designed for women to those designed with women, and shift from siloed sector approaches, and try to see how health, nutrition, financial inclusion actually can reinforce each other in the design part itself, and redirect financing to cover even preventive and indirect costs. Because resilience actually begins long before illness strikes. And what we definitely need to stop is treat women as beneficiaries. India's 93 million self help group members are not recipients, they are actually co creators of resilience. So, when we listen to their lived experiences, we find solutions that balance health, livelihoods, and care together. So, I think overall, it's putting the power and the charge back into the communities and in the women's hands itself. Thank you.
Thank you so much, Nita. So I just would like to echo with all three of you that women should be at the heart, right? So when we develop any program or intervention, we have to keep in mind that this is not by someone else outside, it's them who build their own intervention along with us together. We together build it so that it's an ownership. And at the same time, when the project, and we should shift our mindset from projectized approach, not like solution focus. It's like project focus, and project outcome is so narrowly visioned. So we have to move away and giving the power to those where it belongs. It's women, it's the girls in the society. It belongs to them. So to do that, we need evidence, right? That what we are doing is really impacting them positively and creating impact that we are envisioning. So that's where, like Olga mentioned, that we need lots of research that is creating evidences, and that would be our point of evidence of advocacy. So the evidence will be built on the indicators. That indicators will reflect the perception of the community, perception of women of being resilient and being healthy, and mostly around like prevention, like how to manage their own health so that they are not sick. Even they're not sick, but when they are sick, so they have the right tool in their hand so that they can take the decision and they can raise their own voice that they need the healthcare. So it's not somebody will allow them and then they will go to seek the healthcare. So basically, to make this kind of revolution in the community, we should create make indicators that is reflecting what they want, what they understand, and ideally they can measure the change among themselves. So without involving community in co-creation and involving engaging with them in measuring the impact, is ultimately that what we are doing is not sustainable. It's just ad hoc, and it's a wastage of resources. So thank you all for joining, and thank you all the audiences once again for being with us. And if you have any questions or to the panelists, please do reach out through emails. Thank you so much. Have a lovely day.
Thank you. Take care.
Thank you.
Bye.
Thank you. Thank you, everyone. Bye.
Thanks, everyone. Bye.